Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mammanis, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
This is a 75-year-old female with a history of left ductal carcinoma in situ. In 1999, at that time, the patient was 54 years of age. She was treated with lumpectomy, adjuvant radiation therapy, and 5 years of tamoxifen. She subsequently was diagnosed with a new left invasive ductal carcinoma, grade 2, ER and PR positive, and was HER2 negative. She underwent lumpectomy and sentinel lymph node biopsy and had 1 out of 2 lymph nodes that were positive. And so we want to focus on the management of the axilla and how radiation could complement that. So again, this patient has a history of left DCIS in 1999 at the age of 54. She has undergone lumpectomy, radiation, and 5 years of tamoxifen. Subsequently, now in 2019, demonstrating new calcifications in the left breast, and now we're talking about the same breast. She has a good performance status. Her mammogram had in 2019 demonstrated post-treatment changes in the left medial breast, so a small grouping of calcifications in the upper inner left breast measuring 9 millimeters. She had a stereotactic biopsy that demonstrated grade 2 invasive ductal carcinoma, ER/PR positive, and HER2 negative. She subsequently had multidisciplinary consultation with breast surgery, radiation oncology, and medical oncology, and the options of mastectomy versus repeat breast conservation. And the patient elected to reattempt breast conserving therapy. So she underwent a left radioactive seed-guided lumpectomy and sentinel lymph node biopsy. This demonstrated a 0.4 centimeter invasive ductal carcinoma, grade 2, negative margins, and the largest metastatic focus in the lymph node was 5 millimeters. There was 1 out of 2 sentinel lymph nodes which were positive for malignancy. Dr. Jockelson, do you want to comment about any pertinent findings on the imaging?
So unfortunately, we only have the post-biopsy craniocaudate view. It was apparently a fairly small area of disease to begin with. So the only thing I can say is that she does have some deformity of her medial breast, very possibly from her prior lumpectomy, and a biopsy marker seen medially. I don't see anything that looks like residual tumor on this image, but it's not a complete example.
Thank you so much. So in the setting of her previous breast cancer and prior radiation therapy, does she require an axillary lymph node dissection, or would potentially radiation with high tangents be sufficient? So Dr. Mammaprint, do you want to tackle the management of the axilla first, and then we'll ask Dr. Vicini to weigh in?
Yeah, so, with breast conserving in general, obviously, if a patient did not have prior radiation and had a lumpectomy with sentinel biopsy, 1 out of 2 positive nodes, you would fit the Z11 criteria. So I think not performing an axillary dissection would be reasonable based on that study. Here, things are a little bit more complicated with a prior radiation. So I would sort of turn the question around to the radiation oncologist and ask whether they are able to deliver radiation to the axilla at sufficient dose, essentially sort of how the Amaros trial did it, where patients with positive sentinel node were radiated versus a completion axillary dissection. And since that study showed, decrease in lymphedema, I think we feel like radiation therapy versus axillary dissection is appropriate. Also, the other question, of course, is how does this impact her systemic therapy management? And if the multidisciplinary team requires that more nodes be removed for that purpose, I think that's also one that one can do. But in general, I would shy away from an axillary dissection if the multidisciplinary team feels that they can treat the axilla with radiotherapy in that patient.
Thank you so much. Dr. O'Shaughnessy, do you want to comment about, in this older woman, clearly postmenopausal with 1 out of 2 lymph nodes, is this a patient that, based on the new responder data, would you consider sending this for a recurrence assay, or how would you approach this 75-year-old patient with 1 out of 2 axillary lymph nodes positive?
Yeah, I don't think I would be needing more nodes, to look at to see if she was 4 or more. For example, provided imaging hadn't shown, bulky adenopathy or anything like that. If the axilla had kind of looked clear to start off with, I don't know if she had a mammogram, I don't know if she had an MRI or ultrasound of the axilla or something. But assuming it was negative, I would be comfortable just, kind of thinking about the systemic therapy from her 1 out of 2 lymph nodes positive. It's a grade 2 ER positive, very small primary, so not high risk disease. So I would consider either the 21 gene recurrence score or the 70 gene signature, the MammaPrint. I'd be comfortable either way. We have prospective data in the 1 to 3 node positive for both of those. And if she came back low risk, I would recommend, 5 years and maybe 10, depending on her overall, comorbidities, 5 years hence, but I would recommend an aromatase inhibitor to her, probably zoledronic acid as well, every 6 months. And she's likely to come back low risk, I would think.
Perfect. Okay. So no additional surgical assessment of the axilla, as long as she had a good dedicated axillary ultrasound or MRI in which breast radiology felt that there was no suggestion of additional gross disease. Perfect. Dr. Vicini, do you want to comment about the radiation?
Yeah, actually, this patient's very tricky, as Dr. Mamoun pointed out, because of the previous radiation therapy. Hopefully, we have the previous radiation therapy fields to look at, and we can look at how high the upper border went. If parts of the axilla were actually treated, sometimes they are, obviously, by the tangents. The ideal setting would be where they didn't really extend the tangent superiorly in 1999, in which case we could retreat this patient with high axillary tangents as suggested here and not worry about reirradiation of the axillary region, right? I mean, that's the main concern to me as a radiation oncologist. It's been 21 years since she received her radiation therapy. I'm not concerned about reirradiating the breast. I'm concerned about whatever radiation she received in the past to the axilla. But realistically, she probably got low enough fields through her previous tangents that we could just retreat her with radiation therapy and include the lower levels of the axilla with the high tangent fields. The question really would be whether or not to use a similar fractionation schedule as was used in RTOG 1014, meaning twice a day radiation therapy, 150 sonograte, separated by 6 hours over 3 weeks. That has led to a lower toxicity from the retreatment with radiation therapy. And we always want to try to use that fractionation scheme. I'm not sure I could do it in this setting. So long and short of it, on this particular case, hopefully the previous tangents weren't too high, and I would offer this patient whole breast radiation with high tangential fields to account for the axillary findings.
Can I just ask, Frank, I haven't come across, I don't know that we've reirradiated or done whole breast in somebody who's already had whole breast. It sounds like it might be time dependent. 21 years later, the risk would go down in terms of, bad fibrotic, telangiectatic, et cetera.
Right, exactly. I mean, the longer the time interval, the better to reirradiate, but we've been doing it more frequently using the fractionation schedule that I mentioned, the RTOG 1014 fractionation schedule, and gotten some really good results. The fractionation scheme, that's partial breast irradiation, meaning we don't retreat the entire breast, but that fractionation schedule is tolerated very well, so we can reirradiate. There's at least a couple of dozen studies that have done reirradiation successfully in patients, just like this particular patient here. So I think our concern about reirradiation has really gone down through the years. But as you point out, the time interval is important. Anything over 10 years, we feel much more comfortable, obviously. than something within the past few years.
And just one more question. Could you do partial breast to the area of lumpectomy because it was very small, and then just do an axillary field? Axillary field, provided you're not going to reirradiate the axilla?
You'd have to see how everything falls, right, in terms of in the breast from your tangential fields, whether or not you could do that. Ideally, the scenario would be this patient did not have sentinel nodes positive, and we would just do partial breast irradiation to the region where they did the lumpectomy. Most likely, in this patient, you're probably going to have to combine the breast field with with the axillary field all in one field and treat them the same. They made this case complicated, and, and it really is complicated. It would push the radiation oncologist to really look at the previous fields and figure out what to do. But that being said, we could retreat this patient. I'm comfortable.
Dr. Vicini, can I ask you, is there kind of with the advent of more of the intraoperative radiation therapy, just curious if there's any data for use of intraoperative radiation therapy after patients have had whole breast, or has that only been looked at in patients with very favorable initial tumors?
There have been studies. I'm sure you know the study using target, and also the Veronese study, but that was primary treatment. But they have looked at reirradiation with intraoperative radiation therapy. The problem in this case, of course, is what are you going to do with the axilla? And so you can't really do intraop to the axilla. I wouldn't really know how to do it. But reirradiation, if it's a small lesion, lower grade, negative margins, it's about 5 to 10 years, at least 10 years since previous radiation. Even intraoperative radiation therapy has had a fairly good track record. I mean, partial breast irradiation has been used in that setting, as we've mentioned. I'm not all that familiar with IORT. I've not used it myself personally, but some of the data are good.